Today I'm going to talk about Wilson Greatbatch's invention, the pacemaker. Wilson Greatbatch is widely considered to be the inventor of the pacemaker. He was an electrical engineer who accidentally discovered how to make a circuit that might be able to compensate for breakdowns in the heart's natural circuitry. And then in 1960, 10 human patients received pacemakers. And then the following year, Medtronic, which is a medical device company, received licensing to produce the implanted pacemakers. They had already been making non-implanted versions. And then 1962, Greatbatch received the patent for the pacemaker. And he held this until 1979 when the patent expired. It's not really clear if there's somebody holding it currently. There are many, many manufacturers for pacemakers now and many different kinds. So, yeah, and then meanwhile, he was also working to develop a longer battery life for these pacemakers because for the first decade or so that they're around, the battery really only lasted for 2 years. And since they're directly implanted in the heart, it makes it a little difficult to replace the battery. And he was able to develop a battery that was safe for implantation and increase the battery life to a decade, which is great improvement. This is the picture included in the original patent showing the circuitry that Greatbatch discovered. And we won't talk much about the circuit, but I will talk more about how the electricity generated from this circuit actually paces the heart. So what are the indications for pacemaker implantation? Pacemakers primarily help address arrhythmias of the heart. So anything that is any sort of malfunctioning of the original electrical pulse that causes the heart to beat, or ability to maintain a certain pace. Primarily it's for bradycardia, which is slow heart rate, and tachycardia, which is a fast heart rate. Again, they're very specific instances, but these are the general cases where a pacemaker would be indicated. There's a few different ways that bradycardia can come about. It might be due to drug or medicine use, which would actually be reversible. You could just change the medication rather than implant a pacemaker. But some causes are persistent or long-term, such as AV blockages, which is a blockage right here between the atrium and the ventricle. Also sinus node dysfunction, or problems converting the electrical pulse of the heart to actual muscle contraction that works to pump the blood. So there are many structures in the heart with what is known as automaticity, which is spontaneous action potentials. And we've learned about action potentials in reference to nerves in past classes. And so it's a very similar case in these pacemaker cells of the heart. The primary pacemaker is the sinoatrial node, which is shown here at the top left of the image. And that is because it has the highest frequency of sending action potentials. So if the heart is, if this is not functioning properly, the heart will then revert to other pacemaker structures such as the Purkinje fibers or the AV node. But this is not really what you want to happen because the frequency is much slower. And so the heart won't be beating fast enough. You won't have enough blood going through the body at any given time. So that's when pacemakers can be useful. It's also important to consider that pacemakers need to be monitored. They can malfunction. They can get infected, especially right after they are implanted. And they also need to have software updates and are actually quite vulnerable to hacking. Here is an image of how exactly the action potential works and how it is propagated throughout the heart. So as you can see on the left-hand side, we have the sinoatrial node, which was the primary location of the pacing for the heart. So the green portion shows that as sodium slowly leaks in, there's a depolarization. Once enough sodium leaks in to reach -50 millivolts, there's a quick depolarization where lots of calcium ions enter. And then this is known as the action potential. And then there's a resting period between the red and the green here. So it cannot fire another action potential until it has repolarized. And then after the original action potential is sent with the sinoatrial node, it spreads to the next cell and the next cell and the next cell through these gap junctions, which are shown in green between the cardiac muscle fibers, which are these kind of branched structures. Again, this, and then on the right-hand side, this shows the contractile myocardium. So that's the portion of the heart that's actually beating. So muscle cell, cardiac muscle. And again, there's a certain period where it cannot be contracting because it needs to rest between beats. How do pacemakers work specifically? So there's kind of 3 steps to it. The first step is when it's implanted, or while doctors are trying to get it to work properly for a patient, they will program it to have a base rate. So if the heart drops below a certain number of beats per minute, the pacemaker will kick in and start pacing the heart. Some can also respond to changes in heart rate. So for example, if somebody is working out and their heart rate increases, the pacemaker may increase its base rate to help pump more blood that the person needs while doing this physical activity. The other thing that they can do is if the heart is somewhat able to pace itself with the sinoatrial node, but it's not able to conduct that electricity to the ventricle, then the pacemaker might allow the sinoatrial node to generate the pulse, and then it will actually just stimulate the ventricle rather than both the atrium and the ventricle. So you could see that on the right-hand side, this blue wire is implanted into the atrium and the red wire is implanted into the ventricle. So if the sinoatrial node here at the top is able to fire, but it's not able to conduct, hopefully the pacemaker will say, okay, we have the pace right, but we're not conducting into the ventricle, which is needed to get the blood to actually pump out to the rest of the body. So it will, these lead nodes right here, shown in the blown up image, that is where the stimulation will happen. And so the electric current will pass through and it will stimulate the cardiomyocytes. And then the other really important piece of pacemakers is sensing. So when not only is the base rate important, but also what the heart rate is looking like and how fast the action potential is propagating from one area of the heart to the next. So this P wave here in the blue tells you the frequency of the action potentials within the atrium, and then the QRS wave tells about the frequency and amplitude of the ventricle. And then finally, pacing is the setting that the pacemaker is set to actually stimulate the heart muscle. And there are many, many different factors to consider when implanting pacemaker spot. And then there's also research being done on these wireless light-powered pacemakers. And the idea behind these is that they don't require a battery, and they can stimulate more areas of the heart, and they could actually change where they're stimulating, which could be useful in case people's arrhythmias or hearts change over time. And the way that these work is they're like thin layer of silicon that's placed over the heart, and they're stimulated by light that causes electrons to be excited and leave the silicon and enter in the heart. And so it forms a current through like the photovoltaic effect, which is something that we've discussed in past classes as well. And then possibly most interestingly, there's some work being done on turning cardiomyocytes surrounding sinoatrial node and other pacemaker cells into pacemaker cells. So for example, if the sinoatrial node cells are not able to pace, perhaps nearby cells could be induced to become pluripotent stem cells that could then function as pacing cells.